much for that introduction, and it's wonderful to be here today to talk to you guys about our neck of the woods over in Pittsburgh. So you may not hear me say y'all, right? You say y'all? I say yins. So we're yins in Pittsburgh. All right, so so I'm going to talk to you guys about this topic of long-term health and center it around those individuals who are using wheelchairs for full-time mobility. And so, it was mentioned, Human Engineering Research Labs, and so what this lab is about we have a mission and a vision statement that's shown here, but we want to develop technologies to help improve mobility and function of people with disabilities, and we do this through advanced engineering and clinical research. And ultimately, we want to create a world where all people with disabilities have unencumbered mobility and function so that they can fully participate and contribute to society. And so this is a picture of our building. So we are not located on the campus of University of Pittsburgh because we need a lot of space. We have about 40,000 square foot of building space where we conduct a whole bunch of different kinds of research studies that are centered on this mission and vision statement. And so what I'm going to be talking to you about today is really just a small piece of that pie. And if you ever come into the Pittsburgh area, please look us up. We are happy to open up the doors to you guys and have you look around our facilities. We oftentimes have a lot of visitors come in and visit and tour the labs. It's a really cool place to see if you ever get a chance. Okay, this is just a disclosure statement that I need to include because I wear two hats, one for the VA and one for the university. And so the VA is always like, oh, you need to put this in there, so there's that. We'll skip through there, go to the next. Okay, and the objectives is really I want to talk to you about some of the evidence that we've generated over the years through our research that has looked specifically at performance-related risk factors and how they're associated to the development of overuse-related injuries. And then I want to talk about some techniques and strategies that you can use to help promote and preserve long-term function for these individuals. And so this is a slide that just talks about the problem, which I think was already mentioned, right? And many of you know, it's this. We have a lot of people using wheelchairs, and within that wheelchair-using population, we have quite a few of them who are with spinal cord injury. And that what's happening is that even sometimes within just a couple years of wheelchair use, we're starting to see people develop pain in the shoulders and the wrists. Those are the two most common places. The shoulder is the most common joint that is affected. And then over time, we see this, becoming worse. And also, it can lead to injuries. And so the injuries that we see mostly are related to shoulder impingement. And in some cases, we'll see that get severe enough where you see a rotator cuff tear happen. And so those are the things that are common around the shoulder. There are those others. The carpal tunnel syndrome is really, really prevalent. So just to give you an idea, like in the general population, the prevalence of carpal tunnel is about 5%, whereas in spinal cord injury, it's around 40 to 50%. So it is a very common problem. And like I said, a lot of folks will start complaining of this as soon as very shortly after they start using a wheelchair. So when we started looking into this problem, we went into a very large body of evidence that's out there that's focused around people who are in different kinds of occupations who are also experiencing similar kinds of problems in their upper extremities, so a lot of pain and injuries and that kind of thing. And just looking to see, okay, what have they learned about certain types of tasks and how that relates to the development of pain and injuries. And so these are just a list of some of those evidence-based reviews. And what they had found is that there are some links pretty strong links between certain biomechanical factors and the development of shoulder injuries. And what these studies have also found that is if you can modify the task that a person's performing, or you can improve the fit. So improve the fit of the tool that the worker is using relative to the hand, for example, that this can help to reduce the risk of injuries. So what these factors are, more specifically, is that the factor related to performing a task at a high frequency. And so what they define as a high frequency is performing a task on the order of every 30 seconds or so. And just to put that in, now I'm going to start to talk about how these factors from occupational literature relate to propulsion, for example. So for 30 seconds is a high frequency task. Well, wheelchair propulsion, you're hitting the rim, you're striking the rim just when you're going a casual pace on level road, it's about 1 time per second. So just putting that sort of in perspective, it is a high, propulsion is a high frequency task. And if you add up all the times that a person strikes the rim over the course of the day, it's about 2,000 times for the average wheelchair user. So then you can start to do the math, right? You do 2,000 times a day, how many times, does that add up to over a week or over a month and so on? It's very, very high frequency. High forces is another one that also was strongly linked to injuries and pain. Forces, again, some studies even found as much as 10 newtons of force, which is not that many pounds of force. Performing tasks at that level predisposes somebody to injury. And then the other thing they found was that doing tasks that involve extreme or potentially injurious positions, things like working with your hand above your shoulder, and working with your arms with extreme shoulder internal rotation and adduction are things that also predispose workers to injuries. And so we see all of these things in our wheelchair user population, right? If you're sitting in a wheelchair, you're often having to reach for things that are overhead. And then just the act of going through wheelchair propulsion, which I'll talk more about, and then also a little bit later about transfers, these are arm positions that are very, very difficult to avoid. Okay, so I want to talk a little bit more about wheelchair use and why that might be contributing to some of these problems. And that we find that using a wheelchair, there's a lot of different things that go into that. So it includes things like your stroke technique, wheelchair fit, your postural abnormalities, wheelchair design, and attributes of your disability. And so I won't have time to talk about all these different things, but I'm going to talk about a few things that we have focused some of our research on more specifically. So this is just, again, a little snapshot of one little section of our lab that does some of the biomechanics related research, and this is showing a setup where we have an instrument, a treadmill. So our treadmill has forces of sensors embedded in it. We also use the smart wheel, which is pictured on the right there. This is a custom design wheel that has sensors in it that can record how much force you're exerting in all dimensions. So how much you use in the anterior, posterior directions, superior, inferior, medial, laterally, we get all of that. Any torque that you're putting on the push rim, we can measure that too. And then there are little reflective markers that we put on the body and cameras positioned around the individuals that they can capture the motion patterns that they're using when they're pushing the wheelchair. We've also done electromyography, EMG, which is capturing the muscle activities people use, and sometimes we'll collect the physiological measures too using metabolic equipment. And so with all this information, we have been able to look very specifically at the different kinds of techniques that people are using when they're pushing their wheelchair. And with the treadmill 2 setup, it allows us, it's on a platform that has 6 degrees of freedom, so we can tilt that platform at different angles. We can do cross slopes, for example, and we can set different speeds and that kind of thing. And then apart from this, we have another section of our lab that's pretty large where we can do overground propulsion. So we can capture probably about 10 consistent strokes in our overground propulsion setup. So then once we get a pretty good snapshot of how the person's propelling their wheelchair, we also do a comprehensive examination of the pain and the injuries that they have. So we do this, and we've done this in multiple different ways, using survey-based kinds of methods, as well as very specific methods to look at pathology, such as magnetic resonance imaging. We do neuroconduction studies, which is probably the most specific test that you can do to look at median nerve health. So this gets at the carpal tunnel syndrome. And physical exams and our ultrasound. And what's kind of cool about the ultrasound stuff is that it's a very portable, easy to apply sort of setup. With the MRIs that we try to do on people's shoulders, it gets a little bit complicated. You start to lose people in your studies because you can't do them with everybody because they have metal, which a lot of people's spinal cord injuries have metal in their body. So, or if they're claustrophobic, right? So what you can do with ultrasound is you can, we've developed some quantitative measures to use with ultrasound to look very specifically at the tendons. So we've studied rotator cuff tendons in the shoulder as well as the median nerve more specifically. And when we do these type of studies, what we typically do is we do a pre-ultrasound measure. So we capture what the tendons and the median nerve looks like when they come in, when they're fresh. They're fresh before they start to do any activity, and then we have them propel on a course that's shown off to the right there. It's a little figure-8 course, and they do about 12 minutes of propulsion. When there's a couple breaks in there, but we ask them to push as hard as they can from the center, and they go around a turn, they come back, and they physically brake. So what we're trying to simulate here is some real-world sort of propulsion activity, because we know in the real world you're not just pushing at a continuous pace. I mean, you're starting, you're stopping, you're turning, you're accelerating, and so on. So it's designed to sort of mimic sort of real propulsion situations, and then we do a post-ultrasound. So we do pre- and post-ultrasound to this activity, and we look at changes that are happening at the level of the median nerve and these shoulder tendons. So what do these studies tell us? So the studies that have been done that have looked at, what we did was, again, we correlated how they were pushing their wheelchair to the changes that we see either on ultrasound or changes that we see in pathology. We've done a lot of cross-sectional studies, which means that they come in one period at a time, and you collect all this information, you try to link it all together, but it's very, very difficult to know how they're pushing relates to that pathology, or is it because of the pathology is that's how they're pushing now. So it's important that we do longitudinal studies. Very, very challenging to do longitudinal studies in a spinal cord injury population. It's hard to follow people. We have done that to a limited extent. There have been others that have been a little more successful, honestly, than we have been. They have just larger cohorts of population of spinal cord injury who are interested in participating in research. And so I'm going to try to summarize the things that not only we have done and found, but also those studies as well, and those of others. But basically what these studies have shown is that there's a link between propulsion, biomechanics, and overuse injuries. And what they're specifically showing is that the key, most important factor with propulsion is the frequency. So that is the one thing. If you can do nothing else, you can just try to get people to contact the rim less often, to go a certain speed, you're gonna be doing them a favor. This one has been coming up not only from studies from our group, it's been replicated in other groups as well. That stroke frequency is a very, very key factor for propulsion. Reduce in high peak forces. So peak forces, those are a little bit harder to minimize. Peak force, if you're a heavier individual, you're going to use more force. That's just what's going to happen. So, but there are some things that you can do to help minimize it, and I'll talk about that. And then the rate of loading on the push rim. So it's how rapidly that you're loading the rim with force. That one also has a link to the injuries. And then range of motion. So you may have if you remember from a few slides ago, I said, well, if you're using extraneous ranges of motion, that predisposes you more to injuries. Well, in our studies, we found that actually, if the more range of motion that you have in your wrist, the better off you are. And that is coming into play because when you're using longer pushes, you're using more of your push rim, you're lengthening out that arc, that helps you reduce stroke frequency. So again, it points back to stroke frequency being one of the most critical factors for propulsion biomechanics. So it's not just about the biomechanics and how you push your chair. It's about other things as well. So one of the things that comes up often in many of these studies that have looked at these links is that it's the mass of the person, right? So like I said, the heavier you are, the more forces that you're going to use, it's not just, just being heavier predisposes you to injuries. And so that's something that's a little bit harder to modify. But for the biomechanics, we can modify a lot there. So that is a modifiable risk factor. And there's several things that you can do for this. And so I'm listing the few things that I'll be talking a little bit more about in the next few slides. So we'll start with wheelchair design. So there's, as you probably know, there's different types of manual wheelchairs out there, and they're categorized, and they start with a sort of your basic model, which is like a depot hospital-style wheelchair, we'll say. They're pretty heavy, right? There's not a lot of things you can modify on them. They come in limited sizes, and hopefully you don't have too many people with spinal cord injury who are using these chairs. And then they start to move up. They go into a lightweight category, which these are going to be a little bit more adjustable for the individual. They'll come in more sizes, that sort of thing. They're still a little bit on the heavier side, though. And then you go into this category of the ultra lightweight, which are defined as chairs that are around 25 pounds or so, less than 30 pounds. And so these chairs are definitely the ones that you're going to want to prescribe to people who are going to be long-term using a wheelchair and they're active in their community. So these chairs, and there's been a lot of evidence, and some of this is evidence that's been out there for quite a while, that has looked at comparing the ultralight wheelchairs to those other categories of wheelchairs and have found that they are lasting longer, there's fewer serious frame failures. They cost a lot more, but they're more cost effective because they don't break down as much. You don't have to replace them as often. So they're better investments for individuals. They also have been shown to have some other advantages too. They can help with reducing whole body vibration exposure. So there has been a series of studies that have looked at vibrations in both manual and power wheelchair users. And there's been some studies that have suggested that this vibration exposure that people are exposed to is contributing to things like back and neck injuries and that sort of thing. It's similar to like the truck drivers, right? We have a lot of truck drivers that develop a lot of neck and back pain because of the vibrations that they're exposed to. But you have a similar thing happening in a wheelchair user population as well. And the ultralights can help with that. And then there's other studies that show that they're more comfortable and ergonomic and that they decrease stresses. And I'll talk about some of the ways that they can decrease stress because the ultralights, they allow you the most adjustability that you can provide for an individual. So you get a lot of flexibility with the setup. And there's been a lot of research and work that's gone into looking at things like what's the best setup for an individual. And what I like about these chairs is that you can customize them to fit the anthropometrics of the user. So I'm sure if any of you guys are runners or you run marathons, you're not going to put a shoe on, you're not going to run in a shoe that doesn't fit to your foot properly, right? So it's the same idea for individuals who are using wheelchairs. You want to make that fit as perfect as possible for them. And so they offer things like adjustable camber and adjustable rear axle positions, back seat angles, and so on. I'm going to talk about a couple of these features in a little more detail and some of the evidence on them. So camber, people ask me about camber a lot, but there's really not a lot of good, honestly, evidence, not a lot of good studies, not a lot of good evidence out there about the benefits of camber, but I do think they help with these things. Certainly they're great for increasing lateral stability, and that's why you see a lot of camber in a lot of the sports wheelchairs that are out there. So, and then the maneuverability and turning, it helps with that as well. But really what the evidence says is that in order for you to get all these benefits, and you really need to have cambers that are on the order of like 15 degrees or higher. Okay, so you would never see that in an everyday chair, right? And why would that be? Because it makes you wider. Yeah. So typical cambers that I see are really up to like about 5-6 degrees or something like that. But those are really, like I said, there's not a lot of evidence with that as far as like injuries or preventing pain and that kind of thing. There is some really good evidence around this next one though, and that's probably one of the most critical factors that you want to be thinking about when you're setting up somebody, and it has to do with where the rear wheel is relative to that seat back there. So the more forward you can get this rear wheel on the frame, the better it is for the individual. And the reason why that is that because it brings the wheels in closer to the front of the body. This has numerous benefits to the individual. What it does is it helps increase that access to the push rim. It helps a person lengthen out that push angle, which reduces stroke frequency because they can utilize more of the rim. They have more range of motion on it. And so what this in turn does is it reduces the impact loading on the rims. It also helps to reduce rolling resistance. Well, when we reduce rolling resistance, you reduce forces. So this is another key one because the way that it reduces rolling resistance is it takes less weight off the front casters and it gets more of the weight on the rear casters. When you have the front casters loaded, you're going to have to use a lot more force to move yourself. So it's really good to try to get that weight back, the center of gravity back. So, and then you get some other benefits too. This actually reduces the footprint, so the overall size of the frame gets smaller, and that helps with your turning radius, and so maneuverability improves as well. There are trade-offs to things, right? Every time you look at making a change on the wheelchair in terms of the configuration, you always have to think about what other effects can it have, right? So when you start to bring that rear forward, and you take less weight off the front casters, you start to get more tippy, right? So you lose stability. You lose stability with this. So you have to find that fine line between allowing that person the greatest amount of function as possible, but without, compromising that stability. There's also I talked about the fore and aft position of the axle. But there's also the height of the seat too. So you want to, if the shoulder is too far away from the axle, then that's also going to reduce the amount of room that they're going to have to use that push rim. So it's going to make those contact angles shorter. It's going to require them to use more higher cadences, higher stroke frequency. So there is an optimal position that you can place the shoulder relative to the axle. And if you just have a person drop their hand straight down to their side, their fingertips should be right around the center of where that axle is. And then there's a couple other things you can look at too clinically, but that's a really good starting point to getting this right. Seat drop is another one. We also call it a seat dump. Some people, it depends on how you look at it. This is really designed more as a sort of a compensatory strategy. This really helps to lock in the pelvis for those who have really poor trunk control. So this is just increasing the seat angle. And this has been shown to increase balance. It helps people reach up higher. It helps with their handling skills of the chair. And there was a study that was done just to make sure that increasing seat dump doesn't alter your glenohumeral, kinematics, doesn't make you more prone to having impingement. And so there was a study that was done to do that as well. So that's a good thing. Trade-offs again related to that is that if you put too much seat dump in someone's chair, it could make it harder for them to get out of it for transfers. So again, kind of looking at the positives and negatives of both things there. Seat width, I really have to work with my models a little better because that's really the one on the right that you want to look at. So yeah. But yeah, so you can see if it's too wide, right, you're going to do this chicken wing thing, and you're going to have a lot more abduction, probably more internal rotation. These are things that are predisposing somebody to develop shoulder impingement. So getting this right is also very, very important. So if you don't know about them, there are some clinical practice guidelines. I was fortunate to be able to work on the panel that helped to develop this series of practice guidelines. They are available for free through the Paralyzed Veterans of America, and they have more than just this guideline. There's a whole bunch of different guidelines. I highly recommend that you read every one of them. They're great documents because they're, the recommendations that are based on evidence. And so this just shows the one that's related to where the axle is positioned, as we spoke about. And one thing that you have to keep in mind when you're reading a lot of these guidelines is that at the time that they're developed, right? So this is back in like 2005, I think. And we're quite a few years past that now. We've had some more research that has come around that can help guide where the future is going, or maybe refinement on some of the recommendations that have been made. And so with this one, the evidence that was available at this time, it was based on level propulsion on smooth surfaces. All the research was done that way, and so. But when you think about the context of wheelchair use, it's not all level propulsion, right? It's not, and so it's other types of surfaces as well. So you're talking about ramps and curbs and rough surfaces. And what about, when I'm in my wheelchair, I'm reaching and I'm doing transfers. And what about those things, And how does configuration relate to that? So, and so we say, okay, well, is this really a problem? So we go, we ask people, we talk to them, what are you having problems with? So this was a study that was done that asked a cohort of people, a pretty large cohort of people with spinal cord injury, and said, tell us the factors that are limiting participation in activities in your home, community, and so on. And when they were polled, they said they ranked wheelchair as the most limiting factor that was limiting their participation. That was more of a problem than their impairment itself. And so people with spinal cord injury in this study felt that many of these factors, even things like pain and fatigue, weren't limiting as much as their wheelchair was limiting them. So there's clearly still some issues that we can help to address in this area. And so what are some of the wheelchair users saying? Well, if you're positioning the wheel so far forward, then they're not going to be able to transfer over it. So again, compromise, a trade-off has to be made. So you place the rear axle back so they can be more stable for transfers. Or their chair is not as tippy as they like it to be now because they have to be able to get up ramps. Or I need to be able to bridge over my backrest to get dressed without flipping backwards. And so there's these compromises being made to adjust the axle position to make it more stable and less favorable for pushing over ground, just so that they can be functional and doing other activities. And so this is a challenge to the engineers and to the researchers to say, what can we do about this? And so, because whenever you have static configurations providing suboptimal usability in a given context, the user is almost always going to be exposed to more force and to inefficiencies and so on. And so there's been sort of this concept rolling around in engineers' minds about, how can we make the wheelchairs a little more versatile so that they can work better in different environments and for different activities. And so we did a little study that looked at how if we change the setup to make it more stable, does it help them get up a ramp easier? And it was just a simple question. Can it do that? So we got a wheelchair where we made it into We adjusted things on it so that it would become a very stable setup versus something that would be a little less stable. And we tested those on our KARRN system, which is the treadmill system here, at a couple different slopes. And what we found is we had some individuals in the study that couldn't even go up to 6-degree ramp because in the least stable configuration, because it was just too unstable for them. But when we made it, when we gave them the setup that was more stable, they were able to do it. And then this had implications in terms of some of the other biomechanics too, in that the more stable configuration also they didn't have to use as much cadence. They didn't have to strike the rim as often to be able to go up these ramps. So it did show some evidence that this could be useful for people if they were able to get into a more stable configuration to go up a ramp, for example. And so there's been sort of this idea now about this, dynamic change in configuration to be able to go about and do these different activities in more efficient ways. And so this is Jamie Boswell. I can never say his last name correctly, but he's an individual with a spinal cord injury and an engineer and a researcher, and he is doing some really cool stuff. And this is his design that he was motivated to create because of these problems. And so here in his wheelchair, you can dynamically change the configuration so that you can do different kinds of activities, and you can do things, not just for benefit propulsion, but just to be able to reach for items more easily, or work at a desk in a more ergonomic fashion. And here I have a couple slides that just show, like in the one configuration, like this would be your natural configuration for this would be the configuration you would want for level propulsion, but when you go up a ramp, you can adjust that seat position so you can bring the center of gravity more forward and make yourself more stable, and then that allows you to be able to climb the ramp more easily. So this is a really cool system, and I think we're going to hopefully see more of these kinds of systems popping up down the road here. But, so now I'm going to switch gears a little bit and go into stroke techniques. So we've learned some things about stroke techniques. So if you can't necessarily do a lot with the configuration of the chair, there are some things that you can tell a person, ways that you can tell them to push their chair that might make it better for them. And so this was a randomized control trial that we did that involved 3 groups. There was a control group that got no training. I think they might have gotten a pamphlet. And then there was another group that got a 5-minute video. It was a simple video that showed them how to apply long, smooth strokes. And I'll talk about this in a minute, but use a semicircular recovery pattern. And then alternatively, we had another group that was given real-time feedback. So we used the smart wheels to show them exactly what their contact angle was and what the stroke frequency was. And then we followed them. So we did baseline, we measured everybody at baseline, their biomechanics, and then we trained them and we tested them immediately after training and 3 months later. So what we found in the study was that first off, the training that we provided them did have lasting effects. And the lasting effects were things like they continued to use longer push angles, and they continued to have a reduced stroke frequency. This is very positive things there. In terms of real-time feedback, we either showed them the contact angle or the stroke frequency. We kind of altered between the two. And people told us that getting the feedback on the contact angle was definitely more effective for them for learning than the stroke frequency. So you can imagine if I tell you, okay, go around and push your chair 1 time per second, you're really going to have to think and how to do that probably. But if I tell you, okay, I want you to reach back as far as you can and release on the real rim as far as you can forward, that's probably going to be a little bit more intuitive for you to figure out. So that's kind of what the users told us too, was that it was more intuitive to learn about the contact angle than the frequency. And then probably the biggest thing was that we found no differences in the training outcomes between the instruction-only group and the group that got this real-time feedback with a very expensive wheel. So I'm a fan of the smart wheel, but you know, there's, again, if you can find something like this, and this is something that's really easily translatable, right? It's a 5-minute video. You can show somebody, here's how you want to push your wheelchair, and then they can go out and do it. That's a pretty powerful thing. So that was a good outcome, I think, of the study. And then as far as techniques for everyday propulsions, I mentioned about contact angle, stroke frequency. So there's something that we saw people doing when they release the rim. They either drop their hand underneath, or they follow the path of the rim during recovery, or they come up over the rim when they're recovery, or they follow this double looping pattern that you see on the far right. So we've done a bunch of research on this, and our group and others, and all of them pretty much come down to this, is that there's a semicircular pattern that's the most beneficial for biomechanics. This one helps you reduce the stroke frequency, it helps you lengthen out the contact phase. So it's funny because even though your hand's not in contact with the rim at this point, it still had implications on what you do when you're on the rim. So this is what we tell people to do. Use long, smooth strokes, that minimizes stroke frequency, and then use a semicircular pattern. So I have just a few minutes left here to talk to you guys about transfers, which has been my passion of main area of research over the past few years. And that, yeah, transfers, as you guys know, are super, super critical, right? They're a gateway to full independence. And users tell us that this is one of the most important mobility skills for them to learn when they're in rehab, especially car transfers. We know they're done a lot. What's interesting is that, if you ask people, how do they learn about transfers, many of them will say that they didn't really learn transfers in rehab, and we know there's lots of reasons why this is, right? We were discharging people so much earlier than we used to, right? So we don't have time. There's not a lot of time to teach people how to do proper transfers, and they're not developed. They don't have the strength yet necessarily to be able to do them well. So we have a lot of people out there who are learning how to do transfers, watching YouTube videos, and talking to their peers. And they do predispose individuals to injuries because they involve very, very high forces. So they're not like propulsion. Propulsion's a little bit lower force activity, whereas transfers are a much higher force activity because you're supporting the weight of your body when you're doing them. They are known to increase risk for falls and fractures. They're a very important skill for people to learn. So then I set out this task of, okay, is there a way that we can teach people to transfer so it becomes less injurious for them? There's less forces involved. It's an easier process. So that was my research goal, was to try to find the answers to this. And so what do? We build up a system to help measure it, right? So we have a system in our lab where we have custom plates on the floor that measure forces on both the wheelchair side and the surface that they're transferring to. We instrumented grab bars. Here's probably a little bit better, closer picture of that. So we have a couple grab bars that we instrumented with load cells that can measure the forces that they use when they're applying their hands to a simulated armrest or a grab bar, whatever the case may be. And we can interchange the surfaces. We can test different types of transfer surfaces, that sort of thing. We can collect the forces at the feet. And we can study the motions because we have a full motion capture system that surrounds this setup as well. And so I did a study where I asked people to do specific types of transfers, like position their hands in a certain way, position their trunk in a certain way, move their body in certain ways. And what I found out from the study was that there were a couple techniques that I was showing them that it seemed to reduce those forces on the joints. And the other thing I found out too was that there were a lot of subjects that were using techniques that were producing forces and moments that were even higher than some of the techniques that I was showing them to use. And so it was a lot that we learned from the study, and also talking with clinicians who are very experienced in teaching transfer techniques. We use this information to come up with this tool that's called the transfer assessment instrument. And so the idea behind this tool was to be able to provide this to therapists so that they could use it to do a very quick assessment of their individuals as they're doing a transfer to kind of see, okay, are there certain things that you're doing that might make it, might be increasing forces on your body. And so what it does is it divides the transfer down into individual component items. So the components range from various types of setup components to movement components and flight and landing. And so we use the tool to kind of figure out, so the tool was inspired by evidence, and we developed this tool, and we did do a bunch of validation studies with it, which I'll talk about. But one of the things is we wanted to know how big of a problem is this issue of transfer technique. So we used the tool to study about close to 100 people. 20% of them were women in this study, and most of them had a spinal cord injury, but we had a few others in there as well. And what we found was that, and here's some items that you can see here from the tie itself. So where we saw the biggest problems happening, and you can see that there's not any one of these that they're a problem for these. There's 14 items on this tool that we had responses in every single one of them, right? So not everybody is doing it perfectly. We see a lot of problems in the area of setup, just setting up your wheelchair. And we know, those of you that have worked and taught people how to do transfers, it's so critical, right? Just to get that part right, just to set up that wheelchair properly next to that surface, and to get it close enough, for example, to the surface. And so they're very simple things, but they're often things that people don't necessarily do right. So those were there. The hand grips, the arm positioning, and the hand grips were another area where we saw a lot of errors happening, as well as using the head-hips relationship. So the other thing we did was we looked at how these transfer techniques relate to the soft tissues, and we did the similar kind of thing with the ultrasound, like I talked about earlier, pre and post. Some transfers, they did 18 transfers. Some of the transfers were to a level surface, and some of them were to a surface that was just a little bit higher, so like a 2-inch height or so. And they did these repeatedly, and then we did pre and post ultrasounds to look at what changes in the shoulder joint. And so one of the things, and there's many findings in the study, but this is one of the things we found, is that if people weren't using a safe trailing arm and hand placement, that they had greater changes in their supraspinatus tendons. This is one of the key tendons, right, that we see impingement in a wheelchair user population, and it's a tendon of the rotator cuff. So in those individuals, we saw much larger changes in their tendon pre and post transfer with poor techniques. So there are implications on the soft tissues, and this next slide just talks about how what we wanted to make sure we were doing is that we were producing a tool that if people were using it, that it was going to be able to reduce forces on the body, on the joints. And so we did some studies where we had people do the transfers, and we had a clinician that rated them on a tie, so that's the instrument. And at the same time, we measured the biomechanics of their techniques. And then what we did was we tried to link the two, see how that turned out. So I'm not sure if I had these as videos, but I don't know if the videos. That's okay. Yeah, it's a video, but it just shows how on the left side because the thing that we did was when we did the studies initially to look at the link between biomechanics and tie, we got good results, but they were a little bit fuzzy because everybody does different things wrong in their technique. And so what we did was we brought the people back that had scores that were around 7 out of 10 or lower, and we trained them to do every single part of the tie right. And then we measured the biomechanics again. So what we found was that when we did that we were able to reduce the forces and moments on the shoulders, like quite a bit, like statistically significantly so. And we also saw positive results at the elbow and the wrist too. So if people were following the tie techniques correctly, then we see a much reduction, on the joints. So just in the last couple minutes, then I wanted to talk about some strength and conditioning types of things. So I think that we look at these tasks and we know that these things, again, wheelchair propulsion, transfers, all these things contribute. But what can we do apart from making changes to the wheelchair, apart from the techniques to help protect the shoulders, protect the wrists from injuries? And so with the shoulders especially, I think we definitely can do some things there in terms of strength and conditioning. Because we know, and there's been a number of studies, I only have one here, but there's several studies that show that if a person has weak shoulder musculature, and it's particularly the shoulder adductors, that if they're weak, they're going to be prone to developing pain and injury for sure. And that was just demonstrated in this study. That was a longitudinal study following people for 3 years and following when they got pain and looking at the strength changes there. So that's a very strong association. So we can certainly do some conditioning to help improve the strengthening the shoulder adductors. So very targeted training there. And another study that was also kind of fairly recent, also, because I think there's this thing, that when people, if you have people that are more active, that they're going to be more protective from developing injuries. And so we're not necessarily seeing that. I'm going to put the next bullet up here too, because I think, wheelchair sports, right? We have a number of people who participate in wheelchair sports who aren't developing injuries and pain at any higher rate than people who don't participate in these sports. So, you have to wonder, like, what are they doing? Because they're definitely probably have much higher stroke frequencies than those things overall, right? So I do think it has to do with how well they're conditioning their shoulder joints, how well we're doing with structured exercise in terms of we're not over strengthening, the pectoralis major muscles, because those are being worked already a lot, right? So we're strengthening posterior shoulder muscles. We're flexing. We're doing flexibility exercises with the muscles that are worked more often. And so yeah, so participating in wheelchair sports, I think, definitely should be encouraged for individuals. And there's a number of studies that have shown that doing those sports don't make you at any higher risk than a general population. So, and it has so many other benefits, right? For cardiovascular, for self-esteem, for a lot of different things. So those are all good things. And I think we often need to keep in mind the different propulsion sources that are out there that are alternatives to just your standard, manual, half-inch rim. We have our ergonomic rims now that also, the Surge, if you're familiar with that, came out of our lab as an invention that many people are using. And then we have our, propulsion assist, and then we also have the Smart Drive, which is a very cool technology that people can use. If they're going long distances, you want to preserve shoulder function or shoulder loading, they can attach this very easily, and then all of a sudden they have power assist. So it's a very cool, a lot of very cool technologies out there for preserving limb health. So these are my take-home messages, and yeah, so it's just, using properly configured fitted wheelchairs that are maintained well. I didn't even talk about maintenance, but maintenance is so critical too to reducing forces, and considering our technology options that are out there to help support shoulders, and following the tie. I think if they follow tie, you're going to improve shoulder, elbow postures, reduce forces. And we want to promote exercises that are balancing forces around the shoulder and increase capacity to perform ADLs. So I want to thank you very much for your attention, and turn it back over to Patrick.
We have a few minutes.
Backwards.
Yeah, you push back on the rims to go forward. Yeah. Well, so they came out. So this is another design that was inspired, by a manual wheelchair user, an engineer, and the evidence is still pretty new on this. I think there was a study that was just released that looked at the biomechanics of it. Because the idea, is that it should work, right? I mean, if we're pulling back, we're using more of the posterior shoulder muscles there, upper back muscles. I'm not ready to buy into it yet, honestly. I feel like we need a little bit more information on these before I think we start widely prescribing them. Yeah. But thank you. Yeah.
Any other questions?
So why people would need like these alternative propulsion sources? Is that what you're?
Right.
Yeah. I think we have really strong evidence that shows that if you're using a manual wheelchair for a period of time, you're going to develop shoulder pain and injuries. So I think anything that we can use, and there's a lot of literature that supports that. Anything that we can use that helps to offload the loading, right, is gonna be good for that individual. Because if they get the pain and injury, then it escalates the cost of having to treat that. And
I think one challenge, again, a lot of people listening about is that, we know this, right? We know that the evidence is there for the advocate forward the better computer technology, or better care, not better fit. But our insurance carriers are the ones who push back and say, I'm sorry, you're going to wait until you get your shoulder before I allow you to get that piece of technology. Again, we're fighting one industry at a time. So
right, I know.
I don't
Yeah.
attach so many pieces of research to my letter to say why we're making smart stuff from the get-go rather than waiting until
Right, yeah. Yeah, I feel like it goes back to the first talk in a way, and so much needs to change in terms of our policies and to focus on prevention and not deal with the treating the problem after the fact. And so, I don't have a great answer for your question. I know that these are prescribed often, like in the clinic that we have at the university. I could, see what they were saying in their letters and share that with you to get them justified.
Thank you very much.